Sorry about that. Getting over a cold. Speaking of which, in this sketch, we'll be working through the broad differential for cough, and oh my, is it a broad one. But hey, that's why Sketchy's got your back. We'll break down the different causes of cough into neat little buckets and go through a comprehensive workup, including the tests you should and shouldn't order. Today, we're hanging out at every kid's favorite birthday venue, Captain Hacks, where a kid can have a coughing good time. TM. Anywho, let's get started. A great way to stratify the different causes of cough is by acuity. That is, acute, subacute, and chronic. Don't worry, we'll define what each of those time frames mean when we get to each category. First up, acute cough. See that 3 at the top of the hammer time high striker? That's to remind you that acute cough is defined as a cough lasting less than 3 weeks. Because, come on, when has anyone ever hit the puck all the way to the top? As you might have guessed from personal experience, the vast majority of acute coughs is caused by viral upper respiratory infections such as coronavirus, adenovirus, rhinovirus, and influenza. With URIs, look for classic symptoms like sore throat, nasal congestion, and rhinorrhea. At Sketchy, URIs are represented by that kid blowing her nose. She's also wearing a number 1 foam finger to remind you that it's the number 1 cause of acute cough. Check out that hammer. If you thought it looked like one of those joust weapons from American Gladiators, well, hello there, you non-millennial. For the rest of you, I'm sure that a hammer looks more like a Q-tip. And that's by design. It's our recurring Sketchy symbol for rapid influenza testing. Since influenza is the only respiratory virus we have a treatment for, that's the only one you should test for if your patient shows other symptoms that are suggestive of the flu, specifically fever and myalgias. These symptoms don't usually occur with other viral URIs. Remember these bacterial lanterns? They're lighting up this ball pit to remind you that bacteria can cause acute cough too. Compared to viral URIs, patients with bacterial respiratory infections like community-acquired pneumonia, represented by the dirty lung spot on this kid's shirt, and acute bacterial bronchitis are usually more ill-appearing. Man, this kid is not having a good time. Remember, Braden, it's not water. They're just balls. Look for classic symptoms of fever, represented by our recurring Sketchy symbol, the flame headband, chills, purulent sputum, and pleuritic chest pain. In the case of community-acquired pneumonia, the major blood test abnormality is leukocytosis with a left shift on the differential, meaning a higher proportion of immature white blood cells, most commonly neutrophil precursors like bands and metamyelocytes. That's why the white balls in this ball pit are piling up on the left side. Chest X-ray is key to diagnosis of pneumonia. In typical community-acquired pneumonia, look for a lobar consolidation similar to the design on this floor mat. Interesting design choice, Captain Hacks. That's it for the acute causes of cough. Pretty simple, right? Well, not so fast. Remember that subacute and chronic cough can seem acute early on in their course, so make sure to keep these other etiologies in mind if your patient's presentation doesn't seem to fit the causes of acute cough perfectly. Speaking of other causes, let's move on to the next category of cough, subacute. A subacute cough is defined as lasting between 3 and 8 weeks. The most common cause of subacute cough is, funny enough, a post-infectious cough, represented by these used tissues piled up in that trash can. As you might know from personal experience, even after a respiratory infection has cleared up, that darn cough can linger for several weeks. This occurs because the prior infection irritates all those cough receptors, and it can take them a while to calm down and reset. We mentioned typical community-acquired pneumonia as a cause of acute cough. When that cough persists beyond 3 weeks, it's time to think about atypical CAP, represented by this much happier kid wearing a Let's Get Weird t-shirt. While there are no specific findings that can reliably distinguish typical from atypical CAP in any individual patient, generally, atypical CAP has a more insidious onset and less severe symptoms than typical CAP, which is why this kid looks a lot happier. In atypical CAP, look for fever without chills and dry cough without sputum production. The chest X-ray of atypical CAP less commonly reveals the classic lobar consolidation of typical CAP. Classically, an interstitial infiltrate is more commonly seen. It's important to note, however, that the chest X-ray cannot reliably distinguish typical from atypical pneumonia. Just like in typical CAP, the white blood cell count will be elevated in atypical CAP, often with the leftward shift on the differential. The most common atypical bacterial respiratory pathogens include Mycoplasma pneumoniae and Chlamydia pneumoniae. For more details on community-acquired pneumonia, check out our dedicated sketch on it in the infectious disease unit. One pathogen in particular to keep in mind is Bordetella pertussis. If you remember from Sketchy Micro, our recurring symbol for Bordetella pertussis is the boarded soldier, which is why this overly excited soldier kid's wearing camo. Patients with pertussis will often have explosive fits of severe coughing associated with a distinctive whooping inspiration, much like that kid's cannonballing into the ball pit. No wonder those balls are all shifted left. Anywho, if your patient's cough matches the classic description of pertussis, make sure to order a pertussis PCR. At this point, you might think, wow, there really aren't that many causes of cough after all. Well, hold in your whoop for just a second there. Chronic cough encompasses a great many different etiologies and is going to be our focus for the remainder of this sketch. To help you organize the many causes of chronic cough, let's segment its causes into 3 subcategories: common causes, uncommon ones, and causes you should think about in heavy smokers. There's a recurring sketchy symbol for chronic conditions, the grandfather clock. Notice how it's in the shape of an 8? That's to remind you that chronic cough is defined as a cough lasting longer than 8 weeks. Let's start looking at the most common causes of chronic cough. Our first cause of chronic cough is one of the most common conditions you'll see in the primary care clinic: upper airway cough syndrome. UACS is caused by persistent postnasal drip. Nasal secretions drip down from the nasal mucosa, stimulating cough receptors in the laryngeal mucosa. Just like that drink spilling down the back of that nasopharynx jungle gym, a Captain Hacks exclusive. Postnasal drip itself can be caused by a number of common upper airway conditions, including allergic rhinitis, the most common cause of postnasal drip in UACS, vasomotor rhinitis, nasopharyngitis, and sinusitis. The typical symptoms of UACS include rhinorrhea, nasal congestion, a sensation of liquid dripping in the back of the throat, aka postnasal drip, and frequent throat clearing, in addition to cough, of course. Physical examination will reveal nasopharyngeal cobblestoning, a classic finding seen in allergic rhinitis. How those cobblestones got in there is anyone's guess. Yet another Captain Hacks exclusive, I guess. Upper airway cough syndrome is interesting in that diagnosis is made not by imaging or labs, but by response to therapy. Patients with chronic cough and postnasal drip symptoms should just be treated empirically for UACS with intranasal glucocorticoids, represented by that moon-faced vacuum cleaner, and oral antihistamines, represented by our recurring sketchy symbol, the beast water. If the cough improves, you've nailed the diagnosis. Ouch. Looks like the upper level of this jungle gym is a bit too cozy. That upper chamber represents the sinuses, the site of our next common cause of chronic cough. While chronic sinusitis is one of the causes of upper airway cough syndrome, its presentation and diagnosis are unique. Look for purulent nasal discharge and facial pain or pressure that's worsened when bending forward. Get down! Love me some Arnold. If these symptoms are present and patients fail to respond to initial UACS therapy with antihistamines and intranasal glucocorticoids, order a sinus CT, represented by our recurring sketchy symbol, the black CT cat. Once the diagnosis of sinusitis is made, treat it with antibiotics. Let's keep the common causes coming with another condition you'll see and hear all about in your career: asthma. Uh-oh, set that treadmill speed just a bit too fast, huh? Been there, kid. Been there. Anyways, see that kid's reversed pink hat? That's our recurring sketchy symbol for asthma. Even though asthma is typically associated with dyspnea and wheezing, cough can actually be the only symptom in some patients. This is known as cough variant asthma. Consider cough variant asthma in patients with a history of atopy, such as allergic rhinitis, represented by the kid's runny nose, and skin allergies, represented by those pink polka dots on his clothing. In addition, ask if there are triggers that seem to cause their cough. If you suspect your patient has cough variant asthma, order spirometry testing. Evidence of an obstructive airflow pattern, taking the classic scoop shape, like that logo there, that is reversible with administration of inhaled bronchodilators, hence the inhaler in this kid's hand, cinches the diagnosis. One test that can be particularly helpful in atypical presentations of asthma is bronchoprovocation testing, represented by this marathon challenge sign. No wonder you can't keep up. I wouldn't be able to run 26 miles on a treadmill either. Or like 2. Anywho, in bronchoprovocation testing, patients are given a provocative stimulus, such as methacholine, to trigger bronchoconstriction, leading to a subsequent drop in FEV1. Since asthma is defined by airway hyperreactivity, patients with asthma should experience a much greater drop in FEV1 than those without. For everything you'll ever want to know about asthma, check out our series dedicated to it in the obstructive lung diseases chapter. Next up, gastroesophageal reflux disease. Remember our hurdy-gurdy mouse from Sketchy Path? Well, it's back at Captain Hacks to remind you that GERD is a common cause of chronic cough, especially if that cough occurs at night. Suspect GERD in obese patients with nocturnal cough that worsens when lying flat. Patients may also complain of sore throat or morning hoarseness. If you think your patient's cough is caused by GERD, go ahead and get them started on a proton pump inhibitor, represented by our recurring sketchy symbol, the PPI parasol. Resolution of the cough after a week or two of PPIs confirms the diagnosis of GERD. For more info on GERD, check out our sketch dedicated to it in the gastroenterology unit. All right, there's one last common cause of chronic cough to think about before you start chasing zebras. Well, it's actually a side effect. That's right, I'm talking about ACE inhibitor-associated cough. ACE inhibitors are represented by our recurring sketchy symbol, the ACE card on that video poke machine. What? It's Captain Hacks. Anywho, ACE inhibitors can cause cough as an adverse effect in about 10% of patients. In addition to inhibiting angiotensin-converting enzyme, ACE inhibitors also inhibit metabolism of endogenous bradykinin and substance P, compounds that can stimulate airway cough receptors. ACE inhibitor-associated cough can develop up to 6 months after starting the medication, so make sure to ask your patient for a thorough medication history, including recent changes. Be on the lookout for patients with a reason to be on an ACE inhibitor, such as heart failure, represented by that floppy heart balloon, hypertension, represented by the steam coming out of this angry kid's ears, or diabetes, represented by that container of Dia-Sweeties candy he's holding, presenting with a chronic, non-productive cough. Remember, test writers may be sneaky and mention a condition managed with an ACE inhibitor without ever explicitly naming the medication. Treat ACE inhibitor-associated cough by replacing the ACE inhibitor with an angiotensin receptor blocker, as ARBs don't cause cough as a side effect. In non-smoking patients without pulmonary disease, upper airway cough syndrome, asthma, GERD, and ACE inhibitor-associated cough account for more than 90% of cases of chronic cough. So, when in doubt, odds are that it's one of these conditions. When you've gone through these common causes and still haven't nailed the diagnosis, it's time to think about other conditions. Let's move on to a couple of conditions that deserve special attention in patients with significant smoking history. For that, let's head over to the smoking section. Seriously, Captain Hacks? Welcome to the 1960s, kids. If your patient has a significant smoking history, strongly consider COPD as a cause of their chronic cough. At Sketchy, COPD is represented by a big blue bloater, kind of like this guy smoking his cigar. Look for the 3 cardinal symptoms of COPD: dyspnea, cough, and sputum production. If you suspect your patient has chronic bronchitis, order spirometry testing. In COPD, you should see the classic scooped-out obstructive lung disease flow volume loop, looking very much like that puff of smoke coming out of the blue bloated smoker's mouth. If this finding does not reverse with administration of inhaled bronchodilators, like it would in asthma, you've confirmed the diagnosis of COPD. For lots more on the clinical manifestations and management of COPD, be sure to check out our dedicated COPD sketches in the obstructive lung diseases chapter. The scariest potential cause of chronic cough, especially in heavy smokers, is lung cancer, represented by our recurring sketchy symbol, the cancer crab. The large central airways have a high density of cough receptors, so a tumor in that area can often cause a cough that just won't go away. Suspect lung cancer in patients with significant smoking history with a new cough or recent change in their chronic smoker's cough, or a cough that persists despite smoking cessation. Because of this frightening possibility, all smokers who are evaluated for cough should have a chest X-ray to rule out lung cancer. Most commonly, you'll be looking for a mass lesion, kind of like this one on the server's creepy apron. Okay, I gotta get out of this smoky mess. Seriously. Who puts the smoking section right next to the dining area? Yet another Captain Hacks exclusive. Let's finish up with a whirlwind tour of the cornucopia of uncommon causes of chronic cough. We'll start in the upper airway and work our way down the body. Our first uncommon cause of chronic cough is a condition you might not have heard before: non-asthmatic eosinophilic bronchitis. As you can tell from its name, NAEB is a poorly understood condition related to asthma. Just like asthma, patients have a history of atopy in addition to a chronic, non-productive cough. The hallmark of NAEB, and what differentiates it from asthma, is a lack of airway hyperreactivity. Check out this lady. She's killing the marathon challenge. Let that runner remind you that a methacholine challenge test will be normal in these patients. And therapies commonly used in asthma, like short-acting beta agonists, won't make the cough go away. Instead, NAEB is treated with a trial of inhaled corticosteroids. To confirm the diagnosis, a biopsy of the bronchial mucosa must be obtained, which should show a plethora of eosinophils. Whew, I'm tired just from watching that lady run. Time to loaf around the party room with a cool drink. Wait, why does this pomegranate juice dispenser have green stuff in it? Either way, the big red pomegranate is our recurring sketchy symbol for bronchiectasis, a rare but important cause of chronic cough. The hallmark of bronchiectasis is a cough that brings up incredible amounts of mucopurulent sputum. The word cupfuls is often used, which is why there are cupfuls of mucousy green stuff floating around in this juice dispenser. Mystery solved. If you suspect bronchiectasis, the first step is to order a chest x-ray, which typically shows dilated and thickened bronchial walls, fluid-filled cystic structures, and irregular peripheral opacities, much like the design on that floor mat. Guess that skull and X-bone sign on the juice dispenser should have been a clue that this thing's not fit for human consumption. Anyways, for everything you want to know about bronchiectasis, check out our sketch dedicated to it later on in this unit. There's one final group of pulmonary conditions you should know about that are uncommon causes of chronic cough: the interstitial lung diseases. In patients with a chronic non-productive cough or progressive exertional dyspnea, interstitial lung disease is always something to keep in the back of your mind. At Sketchy, interstitial lung disease is represented by our recurring symbol, the fibrotic lung tree. Since the causes of interstitial lung disease are numerous and varied, the initial diagnostic test to obtain is most commonly a chest x-ray, which typically shows reticular or nodular opacities. However, since there are so many different conditions under the ILD umbrella, no one radiology finding is diagnostic. Learn all about the different interstitial lung diseases in the interstitial lung diseases chapter of this unit. Last but certainly not least, let's get out of the lungs and into the heart. An uncommon but oft-tested cause of chronic cough is mitral stenosis. Say what? Well, long-standing mitral stenosis can cause left atrial enlargement, which can compress the recurrent laryngeal nerve, resulting in persistent cough or hoarse voice. At Sketchy, mitral stenosis is represented by a miter hat being squeezed, this time by that angry pastry chef. Hey buddy, I'm with you. I'd be angry too if those punk friends of Braden's destroyed my cake. Frickin' Braden. For more info on mitral stenosis, head over to the cardiology unit. Do it. I dare you. Patients with symptomatic mitral stenosis will have other findings, including a diastolic murmur on cardiac auscultation and symptoms of left heart failure such as dyspnea on exertion and paroxysmal nocturnal dyspnea. Speaking of heart failure, never forget about it. It's a common cause of many ostensively pulmonary symptoms, including chronic cough. Suspect heart failure in patients complaining of chronic cough, especially at night, and other classic symptoms such as paroxysmal nocturnal dyspnea. Man, some birthday party you got going here, guy. It's okay. My last birthday party looked pretty similar, except mine had less friends. Order a BMP, represented by our recurring sketchy symbol, the BMP blimp, to help you make the diagnosis of chronic heart failure. Typically, levels are greater than 400 in someone with heart failure severe enough to cause symptoms, hence why that BMP blimp is flying high. If you suspect that your patient's cough is due to left-sided heart failure, order a chest x-ray to look for pulmonary edema. Now that we've gone through the differential, let's finish up by reviewing the workup of a patient coming in with a cough. First things first, make sure to ask how long the cough has been going on, as that can narrow down the differential. For an acute cough, the main conditions to think about on the differential are viral URI and bacterial respiratory infections. If the cough has gone a bit longer and you're entering subacute territory, think about conditions like post-infectious cough, atypical pneumonia, and pertussis. Remember, though, that every chronic cough starts out as an acute and subacute cough, so make sure to keep those conditions in mind while you're working up the more common ones. When it comes to chronic cough, the information you obtain from your patient will determine your next step by leading you down one of three paths: common causes, the ones specifically affecting smokers, and everything else. Interestingly, many of the diagnostic tools we employ in working up a cough are actually therapies. Response to therapy can confirm the diagnosis of many of the most common causes of cough. If your history and physical are pointing you to upper airway cough syndrome, treat empirically with oral antihistamines and intranasal glucocorticoids. If the cough resolves, boom, done. If you suspect GERD, empirically treat your patient with a PPI. If their cough resolves after a couple of weeks of antacids, you've got your diagnosis. If you think your patient has asthma, the next step is to order spirometry, an obstructive airflow pattern that's reversible after administration of inhaled bronchodilators confirms the diagnosis. Finally, if you suspect ACE inhibitor-associated cough, the next step to take is to stop the ACE inhibitor and start an ARB. If the patient's cough resolves, well, look at that, you have your answer. If your social history reveals a significant smoking history and you're thinking COPD, do exactly what you did with your asthma patient. Order spirometry testing before and after administration of inhaled bronchodilators. This time, irreversible airflow obstruction confirms the diagnosis of COPD. For everyone else, and for patients who fail empiric therapy for one of those common conditions we described, the next step is to order imaging, most commonly chest X-ray. From there, your imaging findings will further narrow your differential and guide your workup and management. And that's it. Let's get out of here before we all start looking like Captain Hack.